Yeah, sure. Uh, okay, I'm cutting down the call. Huh? Okay, very good evening, everyone. So, with your antennas high up, and let's wait for some more players to add on. Yeah, Blue, Basha, Inamur Sairam, hello, Rai. Okay. Let's watch for one more minute and then we'll start the quiz. We have all interest. So we'll do it. Join. The first question. Flea-bitten appearance of the kidney is seen in which of the following? Hypertension and time's up. Yes, very good. Majority of them answered malignant hypertension. Yes. So what do you find in malignant hypertension? What is flea-bitten kidney? It is they are nothing but because of the thrombotic microangiopathy, there will be thrombosed patches like petechiae things in the kidney. So on when you see it grossly, this is a gross finding, not a microscopic finding. Please remember this. And what you find in acute pyelonephritis, you see pus. And chronic glomerulonephritis, as we age, the kidneys get shrunken. As the disease progresses, the kidneys are shrunken. And renal amyloidosis, it is pale colored kidney. So let's go to the leaderboard and see. Alkamani, Fluke, Basha, Rai, Inamur, Sairam, Suhu. So let me see some more who have joined. And they should. Oh, nice. Well, let's go to the next question then. Question number 2. So we have got 18 members in the play. Granuloma is pathological feature of all, except, I hope you all know what's a granuloma. It's a pathological feature of all, except giant cell arteritis, microscopic polyangiitis, Wegener's granulomatosis, and Churg-Strauss disease. So, in which you don't find the granuloma. Yes, we have 7 answered correctly and 8 were wrong here. So, giant cell arteritis, Wegener's granulomatosis, Churg-Strauss syndrome, and Takaisu arteritis, they're all, we see granulomas. So, granulomas are not seen in this microscopic the systemic vasculitis where small vessels are affected, like microscopic polyangiitis and polyarteritis nodosa and microscopic polyangiitis and some case of Churg-Strauss syndrome, we don't find granulomas. Okay. Then let's go to the leaderboard. Who has answered it right? We see the result is loading. We have got 21 now. Oh, I see a new name here. Right. Inamur Sairam, I've been watching. Alkamani, Fluke, Priyanka, Bhasha, Lily, Ayush. The last, please try to come for the cream batch. Okay, the next question. Please be fast. Which of the following indicators is present in both pernicious anemia and folate deficiency? It is seen in both. Decreased vibratory sensation in the lower extremities, antiparietal cell antibodies, megaloblastic bone marrow, atrophic gastritis of the body and fundus. What is your answer? Yep. Yes, very good. I have majority of them answered megaloblastic bone marrow. And yes, in both pernicious anemia and folate deficiency, there is megaloblastic bone marrow. Decreased vibratory sensation in the lower extremities, it is seen in only pernicious anemia, that is vitamin B12 deficiency, secondary to the loss of the parietal cells, where you have the antiparietal antibodies, the parietal cells which are responsible for the intrinsic factor secretion, and intrinsic factor is responsible for the absorption of the vitamin B12 from the gut, and these will eventually result in decreased B12 deficiency, and that loss of intrinsic factor is pernicious anemia. And it also, loss of these parietal bodies, what does it cause? It causes atrophic gastritis of the body and fundus. So what will eventually happen is they decrease the, it increases the chances of gastric adenocarcinoma. Okay, yeah. Fine then. So we have megaloblastic bone marrow seen both in pernicious anemia and folate deficiencies. Fine. Let's see the leaderboard. Who are on the top? At least someone are trying. The leaderboard is loading. Oh, good. I found all new names. Prai, Paritosha, Lily, Inamur Sairam. Yes, yes. Very good. Keep up. I think I'll concentrate the first and last more now. Okay, question number 4. Increased lipolysis of fat stores, which can result from starvation, diabetes mellitus, or corticosteroids use, is most likely to cause steatosis through which of the following mechanism? So, decreased fatty acid excretion from liver leads to free fatty acid accumulation in hepatocytes. So, give an explanation for everything. Think about the answers. The time is up. Yes, we have 6 wrong answers, 2 right, 2 wrong, 3 wrong, and 5 the right answers. So now what will happen in this free fat? What is a spectrum of, what is the fate of free fatty acids? So the free fatty acids, they are converted to triglycerides, and triglycerides are converted into cholesterol, and from cholesterol they are oxidized to ketone bodies, and from the ketone bodies they are eventually they convert into VLDLs and they are excreted through hepatocytes. So now what will happen in this mechanism is increased fatty acid delivery to the liver leads to triglyceride accumulation in hepatocytes. So that is the answer here. Okay. So that is the reason for steatosis in the cases. So that is accumulation of triglycerides is steatosis. Good. Inamur Sairam. Come on. Now, Luke, Priyank, should see Tabasam, Seshu. Let me see who is not actively participating. Anu. Okay. So fine. Let's go to the next question. Question 5 about liver. So we have true about fibrolamellar carcinoma of liver is all except so the answer is, oh yes, we got a good number of people answered it. But why do you think the answer is serum AFP levels are usually more than 1000 mg per liter? Serum AFP is a marker for carcinoma. So, but as we all know, fibrolamellar carcinoma is not, it has good prognosis. Females do not have increased incidence than males. It means they both are same here. And it is not associated with liver cirrhosis. Yes, and it is also not associated with HBsAg antigens. Okay. So the serum AFP levels, they are usually less than 1000 mg per liter. Okay. So that is fibrolamellar carcinoma. Let's see the leaderboard. Who did it right? Oh yes, we have Paritosja, Prai, Lily, Inamudi, Sairam. Oh yeah, I always see Sairam starting with slow pace and ending up with being the topper. And we have, oh yeah, the curves are moving. Okay, good to see it. Well, then let's go to the next question. Yeah, this question needs, it's interesting. So, a 15-year-old boy presents with epistaxis with multiple non-palpable petechiae on his back and chest approximately 1 week after an URTI. No lymphadenopathy or splenomegaly. CBC unremarkable except platelets of 5,000, which is less, and bone is showing increased megakaryocytes. So, what's your answer? What could be the mechanism? Fantastic. I'm happy. Majority of them wrote correct. It is IgG antibodies against the platelets. So, what do you think is the condition the patient is undergoing? It is idiopathic, thrombocytopenic, purpura. So, what is the prognosis of it? Yes, it eventually leads to remission. It has good prognosis, and prednisolone is the drug of choice here. So, it's not a platelet addition defect, it's not hypersplenism, it is not consumption of platelets. So, when you see this consumption of platelets in clots, in which conditions it is? DIC, disseminated intravascular coagulation. Hypersplenism, no, there are no features suggesting it. And we have a platelet addition defect, which is, in which condition do you see it? Addition defect is in von Willebrand disease. Okay, so fine. Let's move to the leaderboard. Which cream is, I want my board to be filled entirely with complete bars. Yes, very good. That's the spirit. Good to see. Good to see different colors. I just want to see. Okay, guys, come on, answer it. Next question. Question number 7. This is related to your lung. Sorry, the net is, my connectivity is poor, I guess. Question number 7. Bronchiolitis. Asteroid antibodies, giant cells within bronchioles, loose fibrous tissue with bronchioles and alveoli, multiple rheumatoid nodules within interstitial tissue, numerous eosinophils. So, what do you think is the answer? Yes, I'm not very happy with the answers, but still, yes, 2 of you have answered it right. See, what is bronchiolitis obliterans? It is a non-specific reaction which happens in the lung due to multiple infections and inflammations. And please remember this, always due to multiple infections or inflammations, what will happen to the tissue? It undergoes fibrous. And fibrous tissue, if you know the inflammation and the cell response, the fibrous tissue from, if there is any fibrous tissue, it is very difficult for us to get it back. So fibrous tissue is something like end stage of that cell. So here, loose fibrous tissue within bronchioles and alveoli, that is a response which the lung is giving for multiple injuries which has happened to it. So that is the answer here. Asteroid bodies in giant cells within bronchioles is not right. Okay, so bronchiolitis obliterans with organizing pneumonia. Okay, let's go with the leaderboard. Now we have 2 members only answered it right? Paritosh Jha, try. Okay, fine. Let me see the board. I'm still curious how many bars are increasing. Fine, I'm happy to see this last. Good, good. Let's go to the next question. 8th question. Eighth question. So 70-year-old man who has abdominal pain with mass in all abdomen angiography reveals aneurysm of aorta. What is the most likely cause? This is a tough question and it's very simple to answer. Trauma, atherosclerosis, syphilis, and congenital cause. Think 70-year-old man. Yeah, time is up. Yes, I'm very happy. 16 answered, and of 16, we have 14 members answered atherosclerosis. Now, does trauma cause aneurysm? I don't think so. Syphilis, yes. Syphilitic aneurysm, which is, where does the syphilitic aneurysm happen? It is in the ascending aorta. So, do you remember any aneurysm of vasculitis which is in the aortic arch? It is tachysus arteriosus. Otherwise, everywhere it is ascending aorta, be descending aorta, you have abdominal aorta, they're all, you have atherosclerosis as the major cause. So, then we have the leaderboard here. Results are loading. Right. I wish now I should see. I'm curious to see the board. Oh, yeah. I like to see the bars increasing. Oh, finally. Good. It's still oddity. I must have recently joined. Anu, yes, very good. I'm happy. Let's go to the next question. Please participate in the poll. Please answer. So, excuse me for my net connectivity. Question 9 here. Progression into core pulmonale. A patient with which of the following? Mitral stenosis, a ventricular septal defect, pulmonary stenosis, multiple recurrent pulmonary emboli. This also basics. You should get through it. Uh-oh, yeah. Okay, fine. We have 7 answered correctly, 5 answered pulmonary stenosis, 2 with a ventricular septal defect, and 2 with mitral stenosis. And I know, let me clear why it is not mitral stenosis, because you know the mitral stenosis, ventricular septal defect, and pulmonary stenosis. Forget about pulmonary stenosis, but these have left to right shunts, and in all these conditions, there is no core pulmonale involved in it. In what happens in multiple recurrent pulmonary emboli is there is a core pulmonale which results in right ventricular hypertrophy, and eventually there is right increased pulmonary hypertension, and then right ventricular hypertrophy, and then core pulmonale. So this is most commonly seen in COPDs. Okay, so that is the explanation. Let us see the scoreboard. Okay, Paritosha, Prai, Lily, Sairam, Aish Singh, Priyanka, Tabasum, Sujata, Auditi. Oh, fine. 3 more I've added, I think. Fine. So let's go to the next question. Question 10. We have multiple small mucinous cysts of the endocervix that result from blockage of endocervical glands by overlying squamous metaplastic epithelium are called Bartholin cysts, chocolate cysts, follicular cysts, Nabothian cysts. So the answer is yes, Nabothian cysts. The answer is Nabothian cysts. When you cut open the section, you see beautiful, long, small, mucinous-filled cysts. That is Nabothian cysts within the endocervix. And then when you see, where do you see follicular cysts? In the ovary. Chocolate cysts? Yes, it is also seen in the ovary. Endometrial cavity. I think you should read about endometriosis. Beautiful explanation you get for chocolate cysts. And where do you see Bartholin cysts? They are the glands in the vaginal epithelium. So we don't find it in the cervix. So only cysts which we find here in endocervix are Nabothian cysts. Straight answers. So let us see the dashboard, leaderboard. Paritosh Jha, Prai, Lily, Sesha, Sairam, Suhu, Anu, Priyanka, Bahu, Tabasum, Sujata. Come on, push yourselves. So question number 11. 36-year-old man with ulcerative colitis developed pruritus and fatigue. Alkaline phosphatase levels is elevated. The biliary tree appears beaded on barium. I think if you read the last line itself, you get an answer. Acute cholecystitis, cholesterolosis, chronic cholelithiasis, primary sclerosing cholangitis. So what do you think is the answer? Yep, time is up. Fantastic. Most of them wrote 12 answered, and all 12 wrote sclerosing cholangitis. Yes, I don't think you need any explanation for this, right? But let me tell you one interesting thing. Cholesterolosis, being a pathologist, we encountered a lot of gallbladder specimens. But what attracts us more is a cholesterolosis, where you find foamy macrophages within the histology, and outside histology, what you see it is called a porcelain gallbladder. It will have the porcelain architecture. So that's the interesting thing here. Let's go to the scoreboard, and the biliary beaded appearance history is pointing towards primary sclerosing cholangitis. Very good. So good, good, very good. Let me see all 12 who answered. The last ones, I want you to push up. Bahu. Yes. So, excuse me if I pick random names, but question number 12. The normal reticulocyte count in adults is, today are all short answers, short and straight questions. 0.2 to 2%, 1 to 2.5%, 2 to 6%, 4 to 6%. What is your answer? I have to explain this, and I want everyone to write it down. Ooh. Only 4 did it correct. It is 0.2 to 2%. That's all. It's a stuff at, and when it is more, in which conditions does reticulocyte count increases? In hemolytic anemias, where there's more destruction. So, and 4 to 6, who wrote it? That is wrong. See the leaderboard who are on the cream badge. So we have Paritoshja today. He's on the lead. He's on the lead. Very good. Keep it up. Seisha 23. I think first 3 deserves an upload. Try Lily. Who are the others? Okay. Fine. Let's go to the next question. We have 28 players on board. 13th question. Pathological features of brain in AIDS are all except perivascular giant cell invasion, microglial nodules, vasculitis, temporal lobe infarction. It's very interesting. AIDS is an exemption. The human immunodeficiency virus, because rest all other viruses cause vasculitis. Only HIV doesn't have any vasculitis. It does have perivascular giant cell invasion and microglial nodules, yes, because the cells which are affected are macrophages and monocytes. And then these giant cell invasion, it happens in the temporal lobe, yes. So the correct answer is vasculitis, which is not a pathological features of brain in the AIDS. And you have vacuolar myelopathy, diffuse and focal spongiform changes. So let us go to the dashboard. Who answered it? Yep, very good. Very good. Sairam is coming to the top. Fine. 14th question. Interesting question. A 9-year-old girl develops rapid purposeless movements, erythematous rash, subcutaneous nodules 3 weeks after recovery from a severe sore throat. Biopsy from the nodules reveal caseous necrosis with epiloid cells and Langerhans cells, fibrinoid necrosis, focal collections of hematocyte line macro, lymphoid nodules with a starry sky appearance. Yes, very good. I'm happy that 7 members have answered fibrinoid necrosis with lymphocytes, macrophages, and aneurysm cells, where I think you must have got the diagnosis. It is acute rheumatic heart disease, where the child is showing purposeless movements, which is sydenham scoria, the erythematous rush, and the subcutaneous nodules, and the history of UTI. So then here, caseous necrosis with epithelioid cells and Langerhans cells are the classic features of tuberculosis. Fibrinoid necrosis with lymphocytes, macrophages, and aneurysm cells and Ashkoff bodies, that is rheumatoid heart disease. So focal collections of hematocyte and macron, that is not. Lymphoid nodules with a starry sky appearance. You please remember this happens in Burkitt lymphoma, which is caused by Epstein-Barr virus. Yes. We have the leaderboard. Let us skip the leaderboard for now. Let's finish off it. We are taking quite some time because of my internet issues. 15th question. Atherosclerosis of the aorta in an elderly patient would most likely have which of the following physiologic effects? Atherosclerosis. Common sense. Reduce systolic blood pressure, increase diastolic blood pressure, increase pulse pressure, increase capacitance in the aorta. Which one do you think is right? Yep, time is up. Ooh, I wrote. Okay, fine. Now I think you need an explanation for this because majority of them were wrong with this question. Atherosclerosis, what happens? What happens to its capacitance? The capacitance decrease. So that rule out the last question. And then what happens to its resistance? Resistance will increase. Okay. Then what will happen eventually when the resistance is increased, capacitance is decreased? What happens to the systolic blood pressure? It increases. And what is pulse pressure? Pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. When the systolic blood pressure is increasing, obviously the pulse pressure is increased. So the answer is increased pulse pressure. I hope I made it clear. So skip the leaderboard, but I'm curious to see who answered it. Yeah. Okay, good. Next question. 16th question. Pathological process present in disease of bone is Paget's disease occurs in many organs, but let me be precise, it is on the bone. Loss of cortical bone because of unopposed osteoclastic activity, normal osteoid production with increased calcification, abnormal remodeling of bone with increased number of osteoclasts and osteoblasts, malignant proliferation of osteoblasts. Yep, time is up. Very good. I'm happy that majority of them wrote correct, but I found some people who wrote it wrong. Let me give explanation for them. So loss of cortical bone because of unopposed osteoclastic activity, it is seen in hyperparathyroidism. Okay. Normal osteoid production with decreased calcification, it is seen in osteomalacia. Just remember a chalk piece. Now, abnormal remodeling of bone with increased number of osteoclasts and osteoblasts. Yes, there is a deformed new bone which is being formed. Okay. And malignant production of osteoblast, it is seen in osteosarcomas, blasts are all pathological. Malignancies. So now that's the scoreboard. They have urinary. Push the quiz faster. Oh, Lily. Paritoshya, Lily. I'm happy you're in the first board. Okay. Let's go to the next question. Question number 17. The rationale for low-dose aspirin prophylaxis of coronary artery disease is based on the resultant decreased synthesis of thromboxane A, GI, ADP, thrombin. What do you think is the right answer? How does this aspirin acts by? You should know the mechanism of action. Oh, very nice. It is thromboxane A2. That is 9% of you wrote correctly. And I think I have to explain for why is it not thrombin? It is not thrombin. So how does this thromboxane aspirin acts? It acts by inhibition of thromboxane A2 and PGI2. Okay, prostaglandin I2 through cyclooxygenase pathway and arachidonic acid metabolism. I hope you all know that process, right? So A is the right answer. Next question, question number 18. Let's push, let's skip the leaderboard. Okay. Question number 18. So, process of rapidly proliferating glomerulonephritis, crescentic glomerulonephritis, it depends on what? RPGN. Number of crescents, size of crescents, shape of crescents, cellularity of crescents. And let me tell you, it carries a very bad prognosis. The deterioration of kidney starts within weeks itself. end-stage renal failure? Yes, it depends on number of crescents, but majority of wrote cellularity of crescents, which is not the case, and shape of crescents is not at all the case. Number of crescents, yes. Now, what happens to any constant injury? There will be proliferation of the basement membrane and parietal cell secretion, which obviously pulls the Bowman's capsule. There is less space in between, and there will be compromise in the renal glomerular filtration rate, and eventually leads to the damage of the kidney. And what is secreted? The fibrin is secreted in between, and the number of glomeruli affected, it is a number. So that results in the bad prognosis. Let's go to the next question leaderboard, and then to the next question. Okay, come on. Yeah, we are on the 19th question. A 42-year-old woman presents with Raynaud's phenomenon and dysphagia for liquids and solids. Her fingers are tapered and exhibit focal areas of dystrophic calcification at tips as well as telangiectasias over skin. Result of serum ANA is pending. Additional tests which would be most useful in serum ANA positive is anti-SS antibody, anti-centromere, anti-double stranded, anti-Smith. Oh, I think I need to explain this for you. So before going, this is a very interesting question. What do you think is the patient undergoing? It is CREST syndrome. What is CREST? Calcinosis, Raynaud's phenomenon, esophageal dysmotility, S4, systemic sclerosis, and we have sclerodactyly and T for telangiectasias, where the patient is having all those features. Now, what is the anti-SS antibodies for Sjogren syndrome, anti-centromere antibodies for progressive systemic sclerosis, anti-double-stranded antibodies for SLE, and anti-Smith is 100% specific for SLE. So this rules out 3 and 4, and then second anti-centromere antibody is the answer here because the patient is undergoing progressive systemic sclerosis, CREST syndrome. So you see, we'll go to the leaderboard at the end. Let me see. Now I'll skip it. I wish to see new names now on the top. And this time I'm going to read everyone's name. How did they perform? Well, last question of the day, so that you can. 69-year-old smoker with double vision, lower extremity, muscle weakness with exertion, small circular lesion in the right hilum is seen, metastasis throughout is found, and biopsy shows oat cell carcinoma, what has caused diplopia and weakness. So I think we discussed about paraneoplastic syndromes. So yes, we got majority. So what paraneoplastic syndrome is the patient experiencing? Lambert-Eaton syndrome, where antibodies against the presynaptic calcium channels at the neuromuscular junctions are there. And antibodies to acetylcholine receptors at the neuromuscular junctions are seen in myasthenia gravis, and which is a paraneoplastic syndrome found secondary to thymoma. And autoimmune antibody with anti-double-stranded antigen, that's not the answer. Inflammatory disorder of synovial joints with paniform, it's not fitting in the question itself. So that is where we are. Let us see who is the green batch today. Paritosha, Lily, Sesha, 23, Inamuri Sairam. Oh yeah, Paritosha is on the lead. I hope that is the clip art of Aquaman. Oh, that's nice. Fine then. That's for the day. And good night. Keep it up. Keep reading.